Good evening, everyone. Today, I am Dr. Naresh Kumar, OTL BNB trainee from Shija Hospital in Fon. My guide is Dr. Palin, and my mentor is Dr. Lakshmi, HOD of Plastiquest Osmania Medical College. Today, my case is Gigantomastia. Based on the picture given to me, the diagnosis of my case is vaginal hypertrophy left side. So history to be taken for this patient is history of developing a hypertrophic breast since when it can develop whether the growth is gradual or rapid in growth and whether any pain or any symptom over left breast, history of any symptoms, upper back pain, neck pain, numbness, and a broad strap bruise, and the history of I will ask the history of menarche and last menstrual period, history of any medications or hormonal supplements I like to inquire, and history of previous treatment or surgery for the breast, and family history of breast cancer I will inquire. And on general examination for this case, I will see whether the patient have any physical findings, any axillary lymphadenopathy, and whether the patient is nourished, and I will check the BMI of the patient by measuring the weight and height of the patient. And on local examination, the left breast was hypertrophic with areola complex in the left hypochondrium, and the skin of the left breast is having multiple striae and there is no scar present in skin. The left nipple areola complex is wide and asymmetric in position compared to right side, and it is positioned inferiorly in breast mold and lateral to the intended breast meridian, around 5 cm below inframammary fold, facing laterally. The left areola is 6 cm in size compared to right, which is 4.2 cm approximately. Yes, ma'am.
Your slide is stuck. Only first slide it is. History or
okay.
Yeah, your PPT is not moving.
Okay,
Slides are not.
I will reproject, ma'am. Now, ma'am.
Yeah, just advance the slides.
Okay, ma'am. Okay, sir. This is the case of vaginal hypertrophy left side, and history to be taken. And on general examination, I will check any general findings, any axillary lymphadenopathy, and BMI of the patient. And on local examination, the left breast is hypertrophic with nipple areola complex in the left hypochondrium. The skin of the left breast is having multiple striae expanded, and there is no scar present in skin. The left nipple areola complex is wide and asymmetric in position compared to right side, and it is positioned inferiorly in breast mold and lateral to the internal breast meridian, around 5 cm below inframammary fold, facing laterally. The left areola is 6 cm in size compared to right, which is 4.2 cm. There is deficient cephalic and medial aspect of left breast in upper part. Left breast medial fullness present in lower part, mild soft tissue fullness of anterior axillary fold and lateral chest in upper part of the left side was present. There is no abnormal projection of costal margins, no scoliosis or chest wall asymmetries. The right breast is normal in shape with coning. The right nipple areola complex is located corresponding to fifth intercostal space and the right mid-humeral line. I will check for any palpable mass present in both breast. I will examine the axilla both sides for enlarged lymph nodes or enlarged axillary tail of spills. On investigation, yes, sir. Yes, sir.
Yeah. So just tell me, you said I'll check for any palpable mass present. What is your differential diagnosis if there's a asymmetrical unilateral hypertrophy of one breast? Is there a differential diagnosis?
It could be a fibroadenoma.
Sorry, what's that?
It could be a giant fibroadenoma.
Okay. Anything else?
Um, uh,
You're right. Giant fibroadenoma is one. Anything else?
so,
Giant hypertrophy of one breast. Anything else?
Sister,
You are not audible.
hello, hello.
Yes.
Any this carcinoma, I have to rule out malignancy.
Does malignancy cause hypertrophy of the breast?
No, sir.
Is there something which is, they say is locally malignant, but is not really quiet, which causes unilateral gigantomastia of the breast?
Yeah, you almost said that word.
Yes, what?
Cystosarcoma pylori.
That's right. Yes, yes.
Correct, correct. Very good.
Yes. Go ahead.
And on investigation, I will assess the patient for general anesthesia, and I will do ultrasonography or mammogram of the breast. If needed, I will do a MRI.
What is your plan?
So first I will counsel the patient regarding the reduction mammoplasty, and I will ask her whether she is happy about the breast size of the right side, normal breast. If she is not happy about that, I will do a augmentation mammoplasty with that I will do reduction mammoplasty of left side accordingly to the right side size. She is happy about the right breast.
Can you say that again?
If she wants to increase the size of the right breast, I will do augmentation mammoplasty. With that, I will do the reduction mammoplasty of the left breast equal to the increase the right side breast size. I will reduce the left side.
What is easier to do, Dr. Naresh? Is it easier to also augment the right breast, which is already a fairly moderate size, as well as do a reduction mammoplasty on the opposite side, or only concentrate on one breast?
Concentrating on one breast will be easier, but according to patient's wish also we have to ask.
Okay, fair enough. I grant you that. Patient's wish. All right.
And for the reduction mammoplasty for ideal breast reduction, these are the principles. The breast should be lifted to a youthful level. The two breasts should be symmetrical. Translocation of nipple areola complex. Yes, sir.
Yeah, we've read that. Go on.
Appropriate location. The blood supply should not be jeopardized. The function of breast should be preserved. The scar should be minimal. The operation must be in a single stage, and it should be applicable for all forms of deformity present. And the plan of treatment for this patient I will for the skin I will do an inverted T technique or a vice pattern, and other options for the skin incisions are vertical scar technique, a short scar, periareolar, inferior pedicle reduction, mammoplasty, L-shaped short scar mammoplasty, and for the vice pattern, what are the advantages? It is suited for very large breast patients who have massive weight loss and skin excess and good exposure. Nipple elevated for more than 6 centimeter, and
Which
it can
one
be
would you
used.
do for this one? What would be your Dr. Naresh option
Yes,
for this
my
one?
my my choice is to vice pattern, sir.
Sorry,
My choice is inverted T technique.
inverted T. Okay, which pedicle?
I will go for an inferior pedicle. This is my marking for this patient.
Your slide has not moved on, so we can't see.
Uh, you can see, sir.
No, not yet.
Now you can see, sir.
No.
No, we can't see, Naresh. You lost your screen now. Yeah, now we can see your.
Yes, sir.
Yeah. Okay, so you do inverted T with a inferior pedicle, right?
Inferior
So
pedicle.
what is can you tell me what's the blood supply to the breast?
The blood supply for the breast is superior quadrant from the thoracoacromial artery, and the main blood supply from a perforator from internal mammary artery and the perforator from the intercostal artery.
Okay, and what about the nerve supply?
Nerve supply is from the fourth to two, third to sixth intercostal nerve, and the fourth intercostal nerve is the main nerve supply.
Both intercostal. And
Well,
what is supplied? What supplies the nipple?
Fourth and fifth intercostal nerve.
Yeah. Okay, lateral branch. Yeah. Okay,
Yes, sir.
fine. So that is your plan for the reduction. Okay. What are the potential complications for a breast reduction surgery?
The early complications, late complications. I'm having the slide I will show, sir.
No, no. Just enumerate.
Early complications, seroma, hematoma, necrosis of the flap necrosis,
Which flap? How many flaps?
skin flap,
How many flaps are
necrosis.
there? Dr. Naresh, how many flaps are there in
Yes.
inverted T breast reduction? How many flaps are there?
We have so medial and lateral flaps, so superior flap, medial and lateral skin flap,
Okay, so there are
and
two flaps. And
yes, sir. And the inferior.
yeah, the nipple flap, which is the inferior pedicle flap, right? So you have three flaps.
Yes, sir. Yes,
Very
sir.
good, very well said. So you have to look for vascular compromise in all the three flaps, right? So if you
Yes,
have got
sir. Yes,
vascular
sir.
compromise in the skin flaps at your T junction, that's where you will get. If it's a mild compromise, there'll be healing issues. So if it's a bigger one, there'll be a wound dehiscence, and if it's even more
Yes,
compromised, then
sir.
skin loss, right? And
Yes,
if it's the pedicle, then you will get partial nipple necrosis or more, depending upon
yes, sir.
vascular compromise. Okay, what are the causes of vascular compromise in a breast reduction?
One is high tension.
Sorry?
Uh,
Can you hear him? I can't hear him at all.
No, I can't hear him now.
Sir, I mentioned which is your vascularity.
No, you're garbled.
Oh. Can you hear me, sir, now?
Dr. Naresh, can you actually this one switch off your presentation and then can you just talk on the mic? Maybe then
Okay, sir.
improve the bandwidth. Yeah.
Yeah, that's a good idea, I think.
Dr. Naresh, you just speak. Maybe from Shravan can project the slides.
And yeah,
Yes,
just give
sir. Okay, sir.
right. That's fine.
Okay, sir.
And Dr. Naresh?
Yes, sir.
Yeah. So what are the causes of vascular compromise of the flaps in breast reduction surgery?
Sir, eye pedicle length and increased pressure.
Pressure from where to what?
Increased pressure or eye tension closure.
Correct. Very good.
There will be increased pressure.
Again, we are losing you. So I'll just summarize for you. Yes, it is because of either too much pressure or tight closure, which is also quite often because of inappropriate or inadequate planning. So you've left your skin flaps too tight, all right, or not catering for the size of your pedicle. All right. Okay. Within any other question, or should we move on to the next? Milind?
I can't hear anything.
Milind, any other question you want to ask, or shall we move on to the next case?
We are running out of time.
Yeah. Dr. Sandeep, Dr. Radha, shall we move on to the next?